Hi, this is Dr. Nick, and this is Health Tech Net, and we're talking about behavioral health. Jim, over to you.
Thank you very much, Nick, and welcome everybody. Thanks to Doug for arranging this, and I will be quick because I'm really looking forward to hearing what our speakers have to say. But I want to just give you a brief preview. Next month, we're going to do actually two things. We have on the schedule for David and his team to kind of give us an update on what's happening with health policy initiatives under the Biden administration. But David confessed to me yesterday that the Biden administration really hasn't started rolling out any health policy initiatives yet to speak of. So I don't know why David hasn't done a better job of juicing that along more quickly, but given that reality, we decided that we'd go ahead and do that with the notion that we might come along and revisit the topic in the fall. In the meantime, as many of you know, this little company, Seattle-based company called Amazon, is building a second headquarters in Arlington and is now at the point of rolling out some pretty interesting plans for an Arlington Innovation Campus. George Mason University, with whom I'm affiliated, is going to play a major part in that. And we've gotten PJ Maddox, who's the department chair for the College of Health and Human Services, to agree to give us a briefing on what is being planned and some probable timetables for that Arlington Innovation Campus. And I think that's going to be pretty interesting. It should be particularly interesting for this group because they're interested in rolling out some initiatives to attract small companies for potentially giving them office space, potentially giving them different kinds of advice and kind of a home as a place to grow, sort of an incubator-ish environment. So that ought to be pretty interesting as well. So that'll be May, I think it's Friday, May 21st will be the date. And we'll look forward to seeing you all then. So Doug, I'm pointing in this direction. I hope that's correct. Over to you.
Well, thanks. I think I mentioned last month that I've joined Happify Health. In that process, I had the opportunity to understand a lot deeper in the world of behavioral health and understand that it's really just health. So as we move forward, I asked a number of the folks that I've met, both in the DC area, et cetera, to join us today. So we're going to kick off with Risa Greendlinger and Murray Zucker from Happify Health, who are some incredible folks I've had the opportunity to learn from. We're going to follow by Kristen Molnar, who I met through the Mindshare community, which is 1,000 investors and growth company executives in the greater DC area. And she was brought in to do some pretty important work in digital therapeutics and cocaine addiction and methamphetamine addictions. So we're looking forward to that. And coming in cleanup will be Richard Moakler, who's served a number of important roles, but more recently in Sanvello, who's been a leader in behavioral health. And kind of with that, I'll turn it over to Risa and Murray to share about what Happify is doing, and then we'll go to Kristen and then Richard.
Okay, so hello everyone. I do have an almost impossible name to pronounce. It's actually Risa Greendlinger, crazy Austrian name. I'm married to a man named Reed, and I have held elected office, but if I ever ran for a higher position than my local town, I would definitely have to change my lawn signs and take my husband's name and become Risa Reed. But Greendlinger is a silent D combination. So with that, I came to Happify from a company that many of you may have heard of, Livongo, which was purchased by Teladoc. I have lived and worked in the DC, Arlington, Alexandria, Virginia area. I formerly did employee assistance programs before I got into the whole realm of life tech. And my role, as Doug said, is Senior VP for Employer Solutions. And I work closely with Dr. Murray Zucker and I'll have him introduce himself. And we're going to do our Fred and Ginger dance act. We're going to ground on slides, but this is really your forum, your discussion. So we welcome you to interrupt us. We're going to try to be very timely and not belabor each slide. We hate death by PowerPoint. So really feel free to uh, ask questions at any point. And Murray, why don't you go ahead with your intro?
Great, thank you, Risa. And Nick, thank you. And Doug, thanks for putting this together. So I'm Murray Zucker. I'm a psychiatrist. I'm medical director at Happify. And before that, for many years, was senior medical director at Optum Behavioral Health. And prior to that, medical director at HealthNet for behavioral health, as well as having been on faculty at UCLA and involved in private practice and consulting to various aspects of healthcare. So today's topic, thank you for putting this together. It couldn't be more pertinent to what we're all going through in terms of behavioral health and the pandemic. We've got a second pandemic is the behavioral health pandemic, and it's a tsunami of increasing worries about mental health. And everybody's, I'm sure, aware of the anxiety, depression that's going along with the pandemic, and we'll discuss that at length. But family relationships, developmental issues for children, the teen suicide is skyrocketing. The vulnerable population, when we discuss the pandemic, we forget about the vulnerable population, the 20% or so of the population that does have a psychiatric diagnosis. And those people are under even more pressure and getting an exacerbation of what they're going through. And so you see an increase in substance use, eating disorders, and the severely mentally ill are having a tough time. So let's take a look at what the challenges here that we're presented with. How do we get help to all of these people who need help? And this is sort of underlined by the pandemic, but it was very clear that it was a very big problem that had a lot of unmet needs prior. So the big questions here is, can digitization be an answer to the big need going out? And essentially, if you look at digitization, it accomplishes a number of things that fit the need. One is obviously the scale. You can approach many more people at scale with digitization. Number two is engagement. It's not only presenting a format, a treatment, access to help, but you've got to get people engaged. So a digital approach that's engaging is part of the answer. And then you want to look at outcomes. It's one thing to have people access something, but you want to help them and get better. So you really have to measure outcomes. The other thing that it addresses is fidelity. In other words, consistency. People go into a therapist's office and you close the door, you never know who's doing what, and everybody thinks they are rewriting the book about how to do psychotherapy. So, and then the bottom line is data. And you can generate data with a digital approach, and then you know how to steer your course and course correct. So if you take a look at our offering, where Happify is a global company, a healthcare platform that combines digital healthcare. This slide is changing before my...
I am changing your slides because I'm trying to figure out why it's not loaded so that everybody can see the full slide. So
take it out as presentation mode.
Yeah, let's see if that helps us a little bit.
Risa, that's okay. This will show that I memorized all the slides for the past.
All right, so let's just do a little level setting check. Can you see the slides now? Is it better to see it in this annotated view?
I think rather than delaying and trying to work out the full screen display, this is much better and everybody can see them. So if you don't mind, that would be great. Thank you.
We're totally fine with it. All right, go forward, Murray.
Great. Thanks, Risa. So let's take a look at what Happify Health is. It's a global healthcare platform, digital therapeutics, care delivery solutions to improve mental health, physical health, and well-being. And in that regard, we address the employer population, and you can see, we're 6 of the US Fortune 500 companies, 4 of the top 50, and then payers and providers. We have 3 of the largest, the 5 largest national health plans, and also very exciting dealing with pharma and in cooperation with them, building out digital therapeutics. Let's take a look here at what the epidemic is prior to the pandemic. If you look at who's affected by anxiety and depression, look at those numbers. I mean, it's really astounding. 70 million Americans alone, and then it's a worldwide problem, obviously. And at Happify, I think we're got over 100 different countries and 10 different languages. But the main thing here is to take a look at healthcare's meta condition is really the behavioral thing that links many, many physical conditions. Take a look at on the right side, you see that really behavioral is a ubiquitous comorbidity in the following medical diseases. Now, for instance, asthma, 67% of people with asthma have either anxiety comorbidly or depression. So really, when you look at behavioral, it's a symptom of many of these medical disorders. And just as, let's say with arthritis, the doctor should be addressing the pain issue. Well, the doctor also has to address the comorbidity of depression or anxiety. In doing so, the outcomes are much better. So it becomes something that needs to be addressed in all of these and many more medical illnesses. So what to do about this problem is one way is the digitization, as we mentioned, and we've developed a clinical engagement platform. Again, engagement is the key. It's nice to have a platform, but if people don't use it, if they don't stay on it, if it doesn't have results, you're not really going to get too far. So the transformation through digitization is the key, and we can really have quite an effect, as you can see. So if you take a look at this slide, what are the different things that we do? It has to be sensitive and effective outreach campaigns to get people engaged. And it's essentially tailored through personalization to the individual needs of the person. So we're treating one person at a time, and we're actually also treating masses of people. So you can do both. You can achieve personalization and a large population through digitization. Then the mainstay, of course, the centerpiece is the digital therapeutics. And that's really a combination of proven interventions taken into a digital format and then wrapped in an engaging presentation so people stay with it and you have outcomes. We also have a screen and refer aspect so we can really adjust to the entire ecosystem of a health plan, an employer, and a population, and to make sure that they're getting the right care at the right time rather than just one size fits all. And then, as I said before, underlying a lot of this is the measurement and optimization so we can generate data to course correct, show an employer where their workers stand, show a health plan, what direction they're going in, and then further improve the quality of the offering. Underneath all of this at the same time, we offer a peer community so that has as live coaching as well as support, education, and the like.
And before we go on to take you like really inside the, show me how does this truly work, I just wanted to pause. So at the top level of the needs assessment and our approach, that digital first, any questions or thoughts, anything that anybody wants to comment on?
I'll raise my hand and ask a question. It's contextual because it was just published today, but it essentially talked about digital health and SDOH, and the thought was to make digital health access one of the factors, because there are, the number cited in the article was 37 million people without decent access to the internet or capabilities, and in many instances they're the folks that most need that sort of amplification that you're talking about. Have you any thoughts around that?
I'll take a first stab at where we are today, and Murray, you can definitely chime in. So on the enterprise side, clearly we're dealing with employers and their employees, but because in the COVID era, we've been asked to expand to help their adult dependents as well. We're having to grapple and consider that and work with our clients for how to offer access. On the health plan side, we do a lot of work with our health plans for some of their harder to serve communities. So I'm going to turn this over to Murray and Doug to comment further. But yes, I mean, and obviously our infrastructure upcoming bill, if it can pass, will help with more connectivity.
Yeah, and I think that's the key. And Nick, thanks for raising that. The social determinants of health uh, really have highlighted an incredible need. And the population I think that you're referring to, may not have broadband, may not have smartphones, and the like. But we are seeing in general some movements in the public sector for the severely mentally ill, for example, to actually provide them with broadband and phones. It's actually cheaper to give this population access to that, by providing them with the equipment than it is to treat rehospitalization and relapse. So I think that the answer to that has a number of levels. One would be in public policy, and then political and funding, and then what our system of public sector has to offer.
Hi, this is Richard, VP of Clinical Research with Day to Day Health. So one of the things is a lot of digital interventions today that, they're very good with the patient-reported outcomes and improving patient satisfaction and self-advocacy. But I've heard that there's kind of a minimalist amount of evidence still on the clinical outcomes. Is it lowering length of stay? Are people recovering quicker from their surgeries? These kind of hardcore, is it reducing adverse events and readmissions to the hospital that are preventable? How about what and you noted the evidence base there. I'm curious, what's the state of evidence with those hardcore clinical measures versus the patient-reported outcomes measures?
Great question. Now I'll take a stab at that. And you'll see in a few slides some of the outcomes in terms of the reduction of depression, anxiety, the improvement in resilience. And then what you're referring to, the HOER kind of aspect of it,
Yep.
the health outcomes and economic forecasting, we can make mention to some of that as well. We're actively pursuing that to actually partner with employers, partner with health plans, and actually go through claims and showing that exact effect. But just to give you a little taste of that, I was talking recently with one group that's using behavioral intervention post-hospital discharge. Just using behavioral intervention, such as a platform of ours, can reduce readmission rate by up to a third. So that actually it's consideration to go at risk for that population of post-discharge because the results are so good. And that's just with the behavioral aspect of post-discharge. And that's for medical conditions, not psychiatric conditions. So yeah, I think what you're getting at really needs further validation, further sophisticated studies, and it's really looking like the trend is quite robust.
That's right. If you could post maybe the reference or just the names of those, if they have a publication in the chat on that, that'd be great.
And so while Murray's doing that, I'll just advance us a little bit further. And, in a way, this where we're helping people worldwide, speaks to digital access or good internet access. So the UN recognizes 195 countries or territories, and we are actually now in 190. So where are we not becomes the better question to ask, and it's countries like North Korea or island nations that just really don't have reliable internet. Murray mentioned the 10 languages. So this is important because it's not only translating the entire platform, but it's also delivering culturally relevant content. And that can look like making sure that if we're having a video that features sports, that the sports are appropriate to that country, but also the communications that we provide to our health plan, pharma, or enterprise corporation clients, so that the idioms that we're using are also appropriate. And for each country where we have these users, we also have scientific advisors, because one of the biggest barriers to use of any type of behavioral health, whether it's digital or in person, is often stigmatization of mental health, behavioral health. So in order to overcome that, the in-country scientific advisors allow us to configure our platform and our messaging, which we A/B test, to help address some specifics that are related to stigma, say in Saudi Arabia versus Brazil. Um, and the kind of examples of how we adjust our communications. Well, today in New England, I'm in the Boston area, it's snowing right now. And it would be appropriate to have a communication that says, you know, when life is like a bumpy road, because we are subject to tons of frost heaves. But would you really want to use that type of communication for a workforce population in Germany with the Autobahn? I don't think so. So we are always making sure that that we are indeed culturally relevant. And if you can see the bottom of the slide, the languages that we are fully translated in are English, Latin American Spanish, Castilian Spanish, French, Canadian French, German, Italian, Portuguese, which is actually Brazilian Portuguese, Chinese, and Japanese. So we are really finding that we're able to deliver services. So I've actually covered this in terms of, you know, making sure that we're relevant. But one other thing that's interesting to note is that in the pandemic era, managers are hearing more information perhaps than they ever had to have to deal with related to family and work. And many managers are worried about saying the wrong thing. So we've created tools such as the manager's toolkit or team kit to help really develop like a universal language for addressing this intersectionality between mind and body, between mental health, behavioral health, and physical health. And here's a little, you know, example for us of how do we, what's the connection between destigmatization, being better able to evaluate a bigger population and promote better outcomes. So our onboarding assessment is correlated with psychological instruments, and it's also tied in, our outcomes report ties to the results of the onboarding survey, as well as happiness index scores that come from surveys that we do with our users every 2 weeks. And our reporting is aggregated from these individual results. So when you look at our onboarding assessment, it is not going to feel like a psychological instrument. Oh, it's not letting me click through now that I'm in the overview versus the play. But basically, we ask questions about people's gender. We ask questions about their satisfaction, if they're in a relationship, their satisfaction with the relationship. There is some of the demographic information about age, but we also ask about impacts on their life that are environmental, that are work related, and we can configure it so that if, for example, we're working with a company and they have health data that say diabetes or musculoskeletal issues are dominant in their spend if they're self-insured or their RX spending, so that we can ask the individual which of those physical health conditions are prevalent for them. And then when somebody completes the onboarding survey, they're served up program topics that are embedded with interventions. And the interventions are activities that tap into one of the distinguishing aspects of Happify. We started with 2 founders who had had enormous success in the casual gaming industry, and we've repurposed their knowledge of how to engage and keep it sticky and you know, serve up variety for people by turning those games, with the help of our behavioral clinicians and our scientists, to use those games, for example, something called Uplift, where you shoot down hot air balloons with positive and negative words to rewire our brain's neuroplasticity. And we have over 70 programs. An example of a recent development was one called Cope Better with Stress from Racial Discrimination. And that right now is really heavily used. So these programs are designed to last 4 to 8 weeks. You can extend the program track. We don't overwhelm people with the fact that we have more than 70 of those programs and more than 300 guided meditations, for example, and over 3,000 of those interventions or activities. But why do we have so much? Really to meet people on the journey where they are at that moment in time, and to serve up variety, because as human beings, we get bored easily. We also really want to gain trust by always serving up 3 or 4 reasons for why using this program will help them. And we draw on 8 modalities, again, not for the sake of more, but really for the ability to meet people where they are. So if you click on the bubbles that you see on the bottom of the screen, whether you're using it on your phone, your computer, a tablet, you'll be able to see what we use to design this particular Cope Better with Stress track. And for example, I actually experienced some trauma related to the COVID era and its impact on family with the death of my dad. And one of the tracks that I used drew on time perspective therapy, which science shows is particularly effective for people who have had adverse impacts from trauma. We always show who created it. And you see in the center there, the 858,446 number, that's the number of users who are currently using this program, Cope Better with Stress. And that ability to share that with our users just creates a comfort level. And that's all part of, keeping people, getting people to engage and keeping them engaged. Does that make sense? And here's that, in addition to the onboarding, I mentioned that we do a happiness check-in, which creates happiness scores or indices. And these happiness check-in questions are correlated, highly correlated to the PHQ-9 for depression and the GAD-2, GAD-7 for anxiety. And then when it's aggregated, we can provide reporting, which we have a great ability to do segmentation, but because we're HIPAA and GDPR compliant, we make sure that if we're segmenting on a workforce, say by geographic area or maybe even by job type, that they're going to be a minimum number to allow us to keep that de-identification. And so here's another screen share where you can see we are doing essentially pre and post testing for an employer's population, and they can see over time how the symptoms of depression, in this case, from severe to none, are changing as people continue to engage with Happify's programs and interventions. And then, of course, we've talked about engagement and activation. Activation meaning getting people to first start using Happify, and engagement, keeping them engaged over time. And as Murray said, these results are really astounding. They're astounding on 2 levels, from a behavioral health perspective, but even from a digital perspective. I don't know how many of you use a variety of apps, but it's very rare for 50% of our users to be still engaging with Happify 12 months and beyond. And what do we mean? We mean going on Happify 2 to 3 times a week for minutes at a time. And we've been able to show that duration of engagement does have substantial impact on reducing depression, anxiety, stress, and improving resiliency, and linkages to those physical health conditions where depression and anxiety are comorbidities. So here I'm going to turn things back to Murray And again, because we're not in full slideshow, it's not going to animate to show the spectrum, but Murray can talk about, our thesis when we began was that we would be able to help the 70% of people who may think that there's something wrong but afraid to take a next step or are unaware it's really kind of an iceberg issue for them. And we thought that those would be the people that we helped, and that we wouldn't be able to have as much impact for those who are in the severe and moderate. But our randomized control trials have actually shown that we're able to help the full spectrum. So Murray, you want to add some more commentary here?
Yeah,
Great.
so I also want to make a transition to the other speakers, and then we can take questions at the end too. So
yeah, we'll wrap up just with Murray's comments here. Great call, Doug.
Terrific. Thanks, Risa. And just to underline that, in the digital world, activation and engagement are the key variables that measure if you're getting anywhere. So really our results are quite impressive. On this slide, though, I just want to emphasize the point that through our digital format, we are able to impact moderate and severe symptoms as well. So you're absolutely right. The 70% who usually don't reach out to get help really now have access to help that works. As well as the ability, as we mentioned on some of our platforms, to be able to screen and refer if higher levels of care are needed. So with this graph, we can extrapolate and discuss it another time, maybe some of the cost savings, the medical cost offset as well. And just one more point to emphasize before we transition is that everything we do is not only based on scientific evidence-based best practice, but also doing our own internal random control studies that are published, so that is peer review published. So this is really valid. The interventions are valid. How we wrap around digitization and combine CBT, positive psychology, mindfulness, and the others is all validated through studies, which is very unusual in the field.
great, thanks, Murray. Well, if there's a quick question, otherwise, Kristen, we'd love to hear about the work you're doing, because I don't think there's any other company I've seen that has a focused digital therapeutic for cocaine addiction and meth.
I think there was one question in the chat from Murray about the go-to-market model, consumer versus through employers.
Oh, thanks.
The question was, do you engage directly with consumers or through providers who prescribe your technology?
Great. So at this point, it's through health plans and employers, and the plan will be with some of our prescribed digital therapeutics that are in the pipeline that would be prescribed by providers, and we're doing pilots with provider groups on some of these products as it is now. So it's a very good question, and how receptive will the individual provider population be to digital therapeutics? It raises a question. Our product is an adjunct to treatment as usual. Will the provider population view it as a threat, as a replacement? We have to educate them that it's actually an adjunct to improve outcomes.
Great. So we'll have time at the end, but we want to hear DTX for cocaine.
Sure. I will just offer up a couple of slides if you guys are able to see those to maybe set some context. Thank you all again for just giving me a couple of minutes. My name is Kristen Molnar. I'm the CEO of Affect Therapeutics. We founded the business last year to specifically address the growing epidemic in stimulant use. And for those of you who may not be familiar with the meth and cocaine problem nationwide, it is profound. In fact, if you go back to the late 1800s, what you would see is that every major sedative epidemic that we've had in the US has been followed by a stimulant epidemic. And we are in the middle of one. It's not talked about as much as the opioid crisis, but it is affecting millions and millions of lives. In combination, about 8 million people who abuse meth and cocaine on an annual basis. It is, in fact, the leading cause of overdose death west of the Mississippi, and deaths have increased sixfold over the last few years. It is the second most used illicit substance worldwide behind marijuana, and profoundly affecting people's health globally. And it's important, I think, for us all to recognize that this is happening. It's not necessarily gotten the attention of the opioid crisis because historically methamphetamine has been a slower killer than opioids, but that is changing as we see most of the supply in the US coming from industrial centers abroad. It is very pure, it is often laced with fentanyl, and it is highly, highly addictive. I was mortified to see that in the CDC's most recent Sentinel studies, where they go into middle schools and high schools across the country and survey children on their use of drugs, that literally 5% of 8th graders nationwide had indicated that they abused meth in the last year. So it's a profound issue, and it crosses socioeconomic barriers, demographic barriers. We see folks across genders, ethnicities, urban, rural. It's everywhere, literally everywhere. These patients are also very costly on our healthcare system. They tend to be more expensive to treat than opioid users because they are active. So they end up in the ED more often. And they generally have more co-occurring disorders than opioid users. They're more likely to end up in the ER than opioid users. But tragically, despite the depth and breadth of this epidemic, there is no standard of care for meth and cocaine abuse nationwide. There is no treatment sort of national center of excellence. There is no standard of care. When these people do get care, they are typically going into traditional outpatient behavioral treatment programs that don't work for them. And they tend to fall out at in the rates of sort of the high 80%. So it's a truly tragic crisis of epidemic proportions. And I think, again, because we've paid so much attention to the opioid crisis, this is one that has not yet surfaced, although we see it increasingly in a number of states where it is now sort of eclipsing opioids as the biggest health issue. In states, for example, like California, in Nevada, 15% of the population is struggling with a meth addiction right now, 15%, and places like Phoenix in Arizona as well. So it's a big issue. And so based upon the sort of lack of purpose-built treatments, my co-founder and I built this business to really specifically focus on this. And the great news is that we hugely affirm and agree with what Happify, philosophically is doing in terms of digital therapeutics and an approach to digital care. I think if the last year has taught us anything, that these are digital therapeutic programs and digital care programs are absolutely effective. They lower barriers to access care, make it more frictionless. And for behavioral health and mental health issues, in many respects, help take away some of the awkwardness and shame that is often accompanied getting and seeking treatment. In the area of stimulant addiction, all the research has pointed to an intervention called contingency management, which some of you may be familiar with as the most effective treatment for helping these patients. Contingency management is effectively something, if you've got children, you practice it every day and you probably don't realize you do it. It's paying people to achieve certain behaviors. And stimulants, unlike pretty much every other substance use disorder that we deal with, have no FDA approved medical replacement therapy. If you look at everything from the nicotine patch through to methadone and Suboxone for opioids, you realize that the typical intervention or treatment protocol for someone with substance use disorder is really about replacement. That doesn't exist, unfortunately, for stimulants. And as a result, we have to rely on other ways to light up the reward system in the brain in order to drive engagement, which is something that Murray and Risa obviously talked quite a bit about. And so the way that we light up the reward system, the way we're trying to sort of replace that missing dopamine hit is through contingency management. So our program delivers to the patient a digital therapeutic app that provides a behavioral therapy curriculum. I suspect it contains some of the same types of content that the Happify Health curriculum has in certain contexts. But that is also the app through which they gain broader access to our full care program, which includes addiction counselor-led group therapy, biweekly saliva tests that are conducted over video conference, one-on-one coaching, daily sort of cheerleading through our care advocacy team, as well as referrals to psychiatrists for adjuvant medication prescription where appropriate to help with co-occurring disorders that can be quite common with this population, including depression, sleeplessness, et cetera. It is also through the app that the patients experience the sort of rewards system. And so again, leveraging some of the same philosophies around game design theory, what we're looking to do here with patients is drive compulsion loops, much like video games do, to drive patients back. So we leverage both fixed ratio rewards for things like attending group therapy, as well as variable ratio rewards, which rewards streak of behavior for things like abstinence. So on my first clean drug test, I might get paid $6, on my second 10, on my third 15. And in that way, again, we're trying to drive value in future decision making or in current decision making and impulse control to sort of value the future again. For me, what's been really interesting about this space is the fact that there is so little data that exists, in particular as it relates to substance use disorder and the true causal relationships between patient activity and patient state and ultimate abstinence. And so that is one of the fundamental goals of our business, is to amass a corpus of data that can be used not only to help improve our own intervention, but to derive population level insights that we can share more broadly. For example, one of the things that is quite interesting in the research today is that there's a strong belief that retention and treatment ultimately sort of drives abstinence. Now, certainly there is, I'm sure, a correlation between these things, but it is not likely causal. In fact, the causal relationship is probably patient motivation. And yet there's very little that's been done to try to assess early on patient motivation and treatment programs and try to drive it in order to drive long-term abstinence. So that's the sort of work that we're doing with our data analytics team, with the goal not only of understanding how that can affect folks with stimulant use disorder, but other substance use disorders that have demonstrated responsiveness to this type of combination of incentives and behavioral therapeutic interventions. And the proof is sort of in the pudding for us. We've been running a clinical trial in California since December. It has been both extraordinarily rewarding and one of the most chilling experiences in my entire career for a couple of reasons. First, I've spent most of my career in enterprise and consumer technology businesses, and I've never had an experience where I turned on a digital advertising campaign and had to turn it off minutes later because I was so inundated with inbound interest in my product. The pent-up demand for a purpose-built solution for this population is unreal. And so we have had extraordinary response to our advertising for participation in the program, and we've had extraordinary results. These are some of the early results from our early cohorts demonstrating that our retention rate in an 8-week episode of care is about twice that of what you would see published in the literature. For an outpatient treatment clinic, and candidly 23% as a standard baseline is probably generous. It's generally lower than that. But with our most recent cohorts, as we've continued to advance and evolve the program, that's reached the upper 60s. When I share that with researchers who know this space, they are truly, truly amazed at those types of results, that we're able to keep these folks who have severe meth use disorder, as measured against DSM-5 criteria, that we're able to keep and engage these people. And it is truly rewarding work, but there is a lot to be done. And so, finally, I'll just leave you with some of what our graduates are saying. It's for those of you who work in the field of behavioral health, it's a great experience. But it's amazing to me. One of our patients said, look, I started using when I was 7, when my mother handed me a pipe for the first time. And, this is the first time in my life that I have been clean. And this was a 27-year-old man. And so, the opportunity to help these people and to help them achieve abstinence and to improve social determinants of health is the goal here. Hopefully also with collecting data that we'll be able to share more broadly as we understand more about what's really driving these relationships and how we start to really understand and are able to test some of the more nuanced aspects of these types of incentive structures and interventions. So I'll pause there and turn it back over to you guys, and we can open the floor.
I'm almost speechless.
Kristen, just to jump in at the expense of sounding like a fan club here, just to emphasize to the group, I know a lot about substance use as sort of my career, that the brain changes from meth and cocaine use are profound, and the recovery is very difficult. The treatment is very difficult and takes a long time, and retention in recovery is the key to better outcomes. And so this is really incredibly important. And the technology, and are you describing it as a standalone treatment or as an adjunct to treatment programs?
So we're actually operating as a provider, so as a standalone treatment with both the therapeutic app as well as our integrated care team. However, as we are more broadly in market with health insurance payers, we'll likely integrate with provider networks as well. But right now, by having our own care team, it allows us to really control quality. One of the reasons that contingency management has not been broadly leveraged has been just the challenge at administering those sorts of programs at any sort of scale. Digitally, we're able to solve that problem, but that is one of the things. As an aside, someone mentioned earlier the lack of Biden administration health policy. They have come out very strongly on substance use treatment, have devoted over $2.5 billion to helping address the combined opioid and meth crises in the U.S. And specifically have talked about contingency management and the desire to make that a more robust and widely leveraged intervention, given the historic issues that have occurred there.
So I'm going to hold on a second, Richard, please, if you would. Simon has been patiently waiting in the clouds there to ask a question, and I'm just going to say I put something in the chat which I'd appreciate after the fact. Kristen, I was gobsmacked at the cutting of methamphetamine with fentanyl, which just shocked me. Maggie was kind enough to answer it, but Simon, go ahead, please. We need to hold off on the questions so that we get to everybody, and then we'll maybe wrap up after that. Simon.
Simple question. I've seen retention charts like that before, but what happens between week 3 and week 4?
People go through withdrawal. Okay. And we lose them. The withdrawal for this is pretty terrible. And so in particular, if you have a job and it's keeping you awake to go to that job, that is the biggest fall off issue that we often see is the post-acute withdrawal syndrome is very difficult for folks to deal with here. And so in part, one of the ways that we've managed to increase our retention rates even further and help deal with that bubble issue has been to prepare people better for what that looks like. Kits to help them prepare their employers, that sort of thing, so they're able to get through that process. But it's days of real misery.
Thank you.
All right, I want to be sure that we get to all of the presenters before we sort of have more discussion. I know there's some burning questions. Doug, you want to round out the presentations so that we can then get to open discussion, and we can always go past the 90 minutes. This is clearly a highly topical area, so.
No, I think we're seeing some incredible innovation and solutions with Affect, and you know, I've been inside of Happify, and you know, the foundation for what they're doing is incredible. And in the process, I did meet Richard, and Richard, I think putting you at the end, given your background and experience across this field, you know, put you at I know you're in a new consulting environment with a couple of folks. I know Kevin Farrow and Rick Lee, but I think you're the best cleanup for what we just heard in terms of how we can implement and do stuff wisely. I think you're on mute.
I'm sorry, Nick. We were going to try to not do that. Thank you. It's an honor, especially to follow those two tremendous presentations. Kristen, I've not been familiar with your company before. I certainly am with Happify. A brief note about my background. I started my career working primarily in public sector, both on substance use disorder and behavioral health. I'm not a clinician, but primarily in the West. Then I spent 13 years at various pieces of the United Health Group, including the executive team at Optum Behavioral Health and their broader specialty networks groups. Did a lot of work in digital health there. Joined United Health Group Ventures in 2015. Helped conceptualize and found the company Sanvello, which is now the largest online digital health provider for depression, stress, and anxiety, but also has a coaching and telehealth presence around it. I left Sanvello at the end of August last year and then eventually joined Transcendent. Just a bit of disclaimer here. I'm not going to talk a lot about the companies I'm affiliated with, although they'll pop up. So just to be clear, I do currently work with M3 Information, which I'll mention in a minute, and Gomo Health, doing some work on adolescents. And I'll put a plug in at the end for something called the Emotional PPE Project, which is a crucial nonprofit currently providing free behavioral health care services to frontline healthcare responders. They arose about a year ago out of the pandemic and the recognition of the trauma healthcare workers are experiencing. If you go to emotionalppe.org, you will find them quite remarkable. Give them some money. I did. So my challenge was to provide a sort of a general look at before and after the pandemic from the perspective of somebody who spent a lot of time in mental health, at everything from the consulting, payer, and provider perspective. So I mean, we know this story, and a lot of what the Happify team and Kristen talked about earlier exactly fit in here, right? Most people who needed care before the pandemic didn't get it. Most people who got care didn't get evidence-based care. Both Murray and Kristen talked about that in the respective fields. In general, most behavioral health care is not evidence-based. And if you remember that behavioral health care includes pharmacology, most depressants are prescribed, antidepressants rather, are prescribed in primary care. Most of those are prescribed to people who do not receive any other form of treatment. That is not evidence-based care. And a point that Murray raised is that the people who really suffer the most in terms of maybe they don't have the acute behavioral problem, suicidality or cocaine addiction, but are people with comorbid chronic health conditions. And they suffer on both counts, because if you don't treat, and this isn't a myth anymore, there's a lot of data about this. If you don't treat behavioral health in the depressed diabetic, they're not going to do a good job treating the diabetes, and their human misery and their cost to the system are going to be enormously higher. So before the pandemic, it was truly awful in behavioral health. And now that we've had a year of a pandemic, it's worse. So I came here to be the optimist, I guess. We've got more people needing care, and people think of behavioral health and they tend to think mostly of depression and substance use disorders. That ain't it. Their anxiety, PTSD, bipolar disorder, those kind of disorders, statistically, there's more of that than depression. And those were the disorders, eating disorders, which Murray is an expert in. Eating disorders have grown enormously during the pandemic. And folks, both in the treatment and in the emergency response sectors, can tell you about that in heartbreaking ways. Another piece of the mess is that, of course, the pandemic woke everybody up to some degree to behavioral health, like lots of things, particularly in the US. That drove a ton of money flowing into it. That isn't always a good thing. If you think there was a lot of crap out there before when it comes to people pretending to treat behavioral health or pretending to have a digital solution, it's worse now, and some of them have a lot of money, and they are putting up particularly digital health, but not just digital health programs, based entirely on speculation or an evidence-based practice that they've mutilated so far that what they're doing has nothing to do with the evidence base, et cetera. I'll stop ranting. And there's more stress on primary care in a variety of ways. So all the people in bullet number 1 are mostly showing up at their primary care physicians who are not in any way, for the most part, equipped to deal with them. Number 2, primary care itself as a linchpin of the healthcare system was severely hurt in the early days of the pandemic because people were foregoing care. We had this desperate need for healthcare providers, but nobody was going to see the ones who really, hold the system together. Huge numbers of them, went out of business, had to merge, et cetera. So the primary care infrastructure itself is terribly stressed, and their patients were deferring care. So if you were a shareholder for the last year in a publicly traded health insurer, it was pretty awesome, in part because nobody was using healthcare. Well, that's a problem. And it means that there's a lot of people who are sicker than they otherwise would have been, which combined with their behavioral health problems and the fact that they're going to go see their primary care physician means that those primary care practices are in real trouble. I'm going to leave time for questions. So what do we need to do? So cheers to the Happifys of the world and to Kristen. We need more evidence-based tools that aren't just about clinicians. There will not be enough. There are not enough mental health clinicians in the world, much less in the United States, to meet the needs for mental health. So we have to figure out how to test, trial, document, and expand solutions that do not require clinicians. Digital health solutions, peer support solutions are important. There's a growing body of evidence that coaching works in a variety of settings or in combination with digital health, peer support, and/or treatment. We have to expand those tools, but at the same time, we have to be very careful about it. As anybody who's worked in mental health, even if you're not a clinician, as I'm not, knows, mental health is a life or death situation. People are going to die. And when you're dealing with something like that, you can't just be trying shit out, pardon my French. But you need to be doing careful trials and making sure, A, that their work, and B, that if you are using a less intensive form of intervention, you have clear pathways. I love what Happify is doing with their Connect tool, where when it's clear that somebody is not appropriate for their digital health tools, they can get referred into more intensive forms of care. Speaking of which, we need more measurement-based care in the world of care delivery. We need behavioral health clinicians to not just do what Dr. Zucker said at the top of the hour, which is go in the room and reinvent psychotherapy every day, right? That's like making up a digital health tool, not very helpful. We need pressure on to deliver evidence-based care and to use measurement to monitor it. But that said, the reason that a lot of people are not, for example, in behavioral health networks is because the reimbursement is so terrible from the major payers. And so they need to start fixing that, and they need to do it in a way that incentivizes the delivery of evidence-based and measurement-based care. And my personal hobby horse, we need more resources for primary care. If you want to really affect change in mental health in the United States, you need to think about primary care. We need more pay for performance, which has had already a remarkable effect. You know, primary care physicians are going from, I don't deal with that, good luck, to recognizing that that diabetic patient who's depressed isn't going to get better unless they treat their depression. They need more tools in primary care, like the company I work with, M3, to fully assess patient populations. Right now, if you go to see your primary care doctor, the odds are very high that they will give you some version of the what's called the PHQ-9 or the PHQ-8 or the PHQ-2 to measure for depression, and they'll claim they've done a mental health assessment. Wrong, false, that's a fail. If you have anxiety, they won't catch it. If you have PTSD, it won't catch it. If you have bipolar disorder, it might say that you have major depression, and the doc might give you SSRIs, which could in fact cause you lifelong harm. So that is a serious problem, and we need a new standard of mental health measurement that is fully transdiagnostic, but that can also be easily deployed in primary care, like the M3. That's my advertisement for the day. And we need tight in-network referral connections at the level of primary care, just like, again, Happify has at their level, so that I show up in primary care, I get assessed, I clearly need some fairly intensive level of help. The poor primary care practice knows where to send me, as opposed to just saying, look at the back of your card. And that could be true, and should, I hope, in the future be true for everything from digital health treatment and digital therapeutics. So maybe I could use Mooditude or Sanvello or Happify as a digital health support to get me, on track, or maybe, or I might be truly suicidal and need an inpatient stay. But either way, right, we need to support primary care with our data infrastructures, with our policy work at the state and federal levels, with the way that we construct health benefits, all of the above, to support tighter connections between behavioral health and primary care. And we can, there is progress on all these things. For whatever I said earlier about it all being a mess, in fact, each one of these three things, to which, just by perfect examples, the presentations you heard before me, we are making progress on, but it's a long slog. And if you're in behavioral health, I hope you're in on it. That's it, that's me.
Thanks, Richard. So I guess we'll open up the floor to questions to any, either each other or some of the presenters.
Yeah, this is Mark Kessner. Hi, great presentation, guys. I was just wondering, for all three of you, what is the business model? In other words, who's paying for this? And are there licensures or other barriers across states or across countries that, limit the use of the technology?
Go ahead.
Kristen, why don't you go, and then Risa or Murray, and then why don't you play cleanup again, Richard?
Yeah, I mean, our AFEC's go-to-market model is in partnership with health insurance payers. they care for a couple of reasons. One, these patients are very expensive otherwise without treatment. So it actually creates a great incentive to construct value-based contracts with them. And so they agree to reimbursement in exchange for, putting revenue at risk, which we're happy to do. Because certainly we see that just reducing even someone from a severe to moderate level use of meth decreases their costs on the system by 10 to 15 grand. But from a we still have to go through, as a provider, we still have to go through all the state licensure requirements that are necessary in order to be licensed to provide in each of the states. So it's an onerous process. There's no question about that. Despite being a digital and purely virtual provider, we even still have the somewhat absurd requirement that we have to have office space in all the states as well.
So for Happify, it's much simpler, and I'll have Marie add in. Currently, our go-to-market means that employers are paying on a per employee per month basis, and health plans are paying per member. This will change as Happify continues to go down an FDA clearance process and our digital therapeutic becomes recognized as a medical grade therapeutic. And then, for instance, on the employer front, if they're large ASOs, they'll be able to pay for us through claims reimbursement. We do have another platform that we didn't really talk about, which is COPA, which allows us to essentially be a platform factory, and from the open digital technology that we have, we layer in or add conditions. So we started with plaque psoriasis, and there you have companies with prescription drugs for those therapeutics that are paying to advertise to the communities that we are creating of plaque psoriasis patients right now. And on the other side of our digital therapeutics, Sanofi in April of 2019 announced their partnership with Happify, where patients who have autoimmune diseases or other diseases where comorbidities of depression and anxiety are there, when they receive their drug from that pharmaceutical company, they receive the subscription to Happify. So that's currently the model. Do I need any shading or redirection or correction, Murray?
No, you nailed it. I just want to point out historically, this is a great question. I mean, at the end of the day, what's the business model? When you look at our evolution as a company, it started direct to consumer as a wellness app. So it was by subscription. And you can see how over very few years, it's evolved into a very sophisticated, shared risk model, PMPM model, on the pharmaceutical side, a partner with large pharma to develop digital therapeutics for their products for the chronic medically ill. So things have moved very quickly as the field has evolved from the early days of wellness to now a much more sophisticated integration into medical illness and chronic illness.
So can I noticed you had a slide that had multiple countries. And is it fair to say that yours is all digital and not necessarily a licensed prescriber or licensed person?
Yes.
Okay.
As a SaaS product, we don't have the kind of hurdles that Kristen was describing of needing to have offices, et cetera. Yes.
Great, thanks.
But that's a good question. I mean, there are regulations in each of these countries that pertain to digital therapeutics. So that has to be taken into.
We are rolling out a clinical coaching component that's differentiated within the scope of Happify. So that will be in market later this year. But it's to just add supported digital self-care. So we're committed to being not a provider, but a kind of a no stigma way to increase your happiness and health without being, quote, a mental health patient or a PTSD patient or a depressed patient.
Okay.
And the current infrastructure, Mark, to your question about the international pieces, I mean, certainly there's the digital health aspect, which is, and I'm confident this is true for Happify, it was true for my former home at Sanvillo, it's true for Ginger.io, it's true for all the other players. What drives that is global employers. And so global employers really drive a lot of the uniform global digital health distribution for a product like Happify or Ginger or Sanvillo, and they're reimbursing it. So it's they're standing, and then of course it's health system by health system globally. That said, there is also an international infrastructure in place, also driven not entirely by global employers, but by employers for things like wellness coaching, employee assistance programs, and more for telehealth. Although as like not quite as long as Murray, but almost a longtime telehealth veteran, global telehealth is brutal from a regulatory perspective. But those EAP and coaching networks certainly, I know a number of people in that world do exist, and are rapidly becoming digitized.
Thanks.
Can I ask a question?
Yeah, go ahead. I know Jim Oates been asking questions in chat, so we should go to those next.
And also just when we get to the end, I just also want to give a pitch about our upcoming June meeting too.
So I'm sorry, did you want me to ask or go to Jim Oates'?
Yeah, go
Okay, hi everyone. Thank you for your presentation. I'm Erkan Hassan. This is a very near and dear subject to me. As a PharmD, I spent a number of years during my training working on a volunteer substance abuse group, and where we would actually go in and take over a middle school science class for a whole week to go over pharmacology of drugs of abuse with the students, and also spent summers with one of my colleagues going to the city jail, which my kids cringe at when I say I spent the summer with Harry at the city jail, talking with the inmates that were in drug abuse programs. So my question is, this is great. I really, and Kristen, the whole cocaine thing, and as rats will give up food pellets to get cocaine, and to the point of not eating. But what about moving downscale to really addressing the problem before it becomes a problem with the younger kids and train education and that type of aspect to this?
Well, yeah, I mean, sure, right. I think we've got from a public policy perspective, we have a lot to be done. I mean, I don't think anyone would argue that. Well, some might. Enforcement efforts over the last decades have done little to curb usage, and so we really have to redirect, I believe, public policy towards education, early education and intervention, to and better treatment programs, as opposed to further incarceration. It's not doing much.
But I meant in terms of your guys' strategic corporate approach,
yeah,
to try to address this is really my question.
Yeah, well, I mean, look, while we're seeing increased usage and with middle school and high school folks, I think, the predominant abuse is still happening among, adults sort of, 18 to 54. That's the general population that we're seeing right now. I think as we move more aggressively across the country, we'll be looking to partner with, in particular, looking to partner with providers in the regions where we're operating, in hopes that we can get to families, we can get into communities, we can start to educate people, and we can start to move down market, or sort of down into those lower age brackets. I mean, it's going to be a problem across the board, right? But sorry, go ahead, Richard.
I just to say, I want to put in a plug here for a couple Orcon nonprofits that do really good work there. One of which is Mental Health America, which does really good work across the board, but is heavily invested in adolescent and young adult behavioral health prevention and not just intervention. And the other one is a fantastic organization called the JED Foundation, JED Foundation, that is explicitly centered around prevention and early intervention in both at all levels of education, because that's where kids are for the most part, and they do tremendous work. They were founded by some parents whose son lost their life to suicide. Truly great organization, nationwide reach, powerful programs.
Jim Oates asked some questions. Are there applications to individuals suffering cognitive decline like Alzheimer's embedded in your solutions?
So I'll jump in. With Happify, no, but in the general world of digital development, I have been privy to some programs that are in development that are using digital transformation to help identify mild cognitive impairment. But as of yet, I mean, there've been a few trials of programs to help brain health and slow down Alzheimer's. They haven't been proven to be too effective. However, there's a lot of attention and money in this space. For example, Otsuka Pharmaceuticals coming out with an Alzheimer's drug, and they're really looking to kind of own the mild cognitive impairment and dementia space. So there's a lot of activity in this area, a lot of research, but as of today, I don't know of any digital programs addressing that specifically.
There is a great company called that's and a program. It didn't start as a digital health program, but now it's been digitized, called Brain Savers, which is was founded by a MD neurologist who's a professor at the University of Arizona Med School. But they're more focused on prevention, and they're more focused on what has been proven. So as Murray said, there's not a lot of interventions that have been shown to help that are the brain type stuff. But what really does work is lifestyle interventions. You get healthy, it helps your brain. Activity, engagement, music, relationship. And Brain Savers has a tremendous program for that.
Quickly, a quick question for Kristen, and then I'll turn it back over to Nick to wrap. Does your roadmap include other addictions like smoking or obesity, eating, or are you going to stay kind of focused on your sweet spot of, no pun intended, cocaine and meth?
Yeah. Yes, over the long term, we absolutely, as I mentioned earlier, will be looking at, we will be commencing research in other substance use disorder areas that have demonstrated responsiveness to contingency management. A lot of research has been done across a lot of sectors. I mean, contingency management is being used for to promote vaccinations, med adherence. Some research has been done into obesity. There's a wide array of areas where it has been used. I think in some areas, quite candidly, the research is a little murky. And so certainly before we embark upon it, we want to look at those areas where there's really an abundance of information that would suggest that, yes, it is better. It's better than prevailing alternative treatments, and and it's a cost-effective approach because it's not inexpensive, obviously, and so one has to consider that as well, and considering an approach that makes sense.
And Doug, just to jump in to answer the question, in the area of eating disorders, there is a company that's fairly new that's really getting a lot of attention for digital and virtual approach to eating disorders. It's a very difficult subject.
Mm-hmm.
Well, overall, we have a stress, in my work in blue zones and stuff, we have a stress-filled society, right? and it's gotten worse in COVID, but, we live by stress, and we're workaholics, and that's sort of the consumer culture underlaying of our whole economic system is to be consumers, not sustainers. So, you know,
it goes deeper and longer than that. We've got millennia of Darwin development that has programmed us to be feast or famine. And, you know, that you're fighting that on a daily basis. If you're not, please let me know, because that's what I am.
I don't know, I might have more Neanderthal than you. I'm not sure.
Well, we need to go to 23andMe and check that out, Doug. I want to know. So,
well, I don't know. The question is, who gets that data then? So we're not going to go there in this session about the data from all these digitized activities and digitized lives. Oh,
well, I would say though,
Alexa.
I would say, Doug, one good news or piece of good news is that we can use all of Kristen's company's office space around the country to put people to do these analyses. So
that'll help with the cash burn too. So it's like a win-win for everybody, right?
I don't know. I did invite Richard Wright from e-Psychology to this, and he had a conflict, but they have a provider network in all 50 states, Kristen. So I don't know if that may make your life easier. But
yes, I'd love an intro, because he might have a closet in every state I could rent from.
Well, yeah, so I think you could have a nice synergy there. They're not a new, they've started organically, and they've grown this nationwide provider network, and I think they've worked with, you know, somewhere over 10 to 30,000 licensed providers in every state, and they have a profile, all these providers, so they could probably cut the profile of their providers to find you an appropriate provider in every state that you want to serve. So,
yeah.
Okay, folks, I want to just don't go quite yet. Let me just round out the conversation. Thank Doug for putting this together. Fantastic program. Thank our speakers, Risa Greendlinger, Murray Zucker, Kristen Molnar, and Richard Mockler. Thank you very much. I think I have one word that sort of describes all of this. It's gobsmacking in terms of the impact that this is having on our society. Such an important space. I'm not going to close the meeting if people want to just hang around for a little bit, but I am going to stop the recording and say that this is the end of the Health Tech Net program talking about behavioral health. Thanks to everybody for joining us.
Let me, before